Okay, so we've made it through our talk about selection bias. We're now moving on to information bias. Hopefully you guys can breathe a little easier. Information bias, in my mind, is a lot more of a tangible error. You can kind of see what happens when you have information bias, and I think, I don't know, I can relate to it more. But if you've totally understood selection bias, then fantastic. Okay, so what do we mean by information bias? Again, it's another type of systematic error in the way we conduct our studies, such that the answers we get are not estimates of causal effects. They are incorrect associations because we've done our study wrong. And in this case, we've collected information as part of our study wrong. So specifically, information bias is systematic flaws, so consistent flaws, consistent errors in obtaining information about exposures and or outcomes. Basically, the information you gathered is incorrect because of the way you gathered it or what you did. It occurs after the study has started, so that's how it's sort of different than selection bias. It's not about who's recruited into your study. It's, the information you collect as part of your study. Again, pertains to how the data are collected. And it, as I said, results in an inconsistent, incorrect classification of participants as either exposed, unexposed, there's a typo there, or diseased, non-diseased. So again, think about your 2x2 table. Say we wanted to measure someone's smoking status. If the measure we used is wrong, and it's consistently wrong, what might happen is that we have people who are truly smokers and they are consistently categorized as non-smokers. So say, as a very specific example of this, say you had a question that said, have you smoked a cigarette in the last 12 hours, right? And so it's a pretty short time frame, right? So you might only capture heavy smokers who say, yes, I've definitely smoked within the last 12 hours. But maybe you don't capture your smokers who smoke, a couple of cigarettes a day, and you ask them this question at 8 a.m. and so they hadn't, they had been sleeping or whatever. As you can start to see, it's going to underestimate the prevalence of smoking in your study population, because it's only capturing those heavy smokers who smoked in the last 12 hours. So a lot of people who may be regular smokers but just haven't smoked in the past 12 hours are going to end up in your unexposed group, your non-smoking group. They're going to consistently end up there because of the way you collected your information and the way you defined your smokers and your non-smokers. It's a problem. You're going to end up with errors. Okay, so it happens a lot. There's, as with selection bias, there's a lot of sort of specific ways that it happens. So I'm just going to go through a few of the specific ways because I think it gives you, again, a sort of, maybe you can latch on to a few of these ideas and be like, oh yeah, I could see that happening. Okay, so it happens, oops, sorry. Gosh, I have a lot of information in this slide. It happens with identification of outcomes. So you're doing a cohort study, and you need to be able to determine who has your disease endpoint, who has cancer, who has coronary artery calcification, right? Some things are pretty clear, if someone's dead or not dead, that's pretty clear. But a lot of our disease outcomes actually, it takes some skill or some precision to be able to accurately classify who has your outcome. So when determining disease or mortality endpoints in cohort studies, study physicians often evaluate medical records, diagnostic results, etc. So you may have someone looking at an MRI or looking at an X-ray and deciding, yes, this person has this disease outcome. And so there's error introduced in that, right? People may mistakenly say someone does have the outcome and someone doesn't. What happens? So there's some random error. There's going to be some mistakes in reading those MRIs or PET scans or X-rays, but it's systematic error. Systematic error can occur. So what if your physicians know who in your study were smokers and non-smokers, right? They're going to be looking at those X-rays very differently. And a physician who knows what someone's exposure status is or was, depending on what they're still doing, unintentionally may make a different decision, right? So if you know someone was a smoker and you're looking at a lung X-ray, you may be more likely to categorize that person as having lung cancer than you would have otherwise. So it's not a random mistake that, this one person happens to be diagnosed with lung cancer and the other one not. It's that the doctor has knowledge of the person's exposure status and they're systematically diagnosing lung cancer or a certain stage of lung cancer, let's say, among the smokers when they're not doing that among the non-smokers. Again, you can start to think about our 2x2 table, and it's those exposed, diseased people that are being misclassified. They're being put in the wrong cell because, in this case, the physician is aware of their exposure status. We've already talked about recall bias, and it's right when in case control studies, when cases report their exposure history different than controls. Gosh, my student really has some typos in this one. Don't worry about this, guys. So again, in recall bias, this may occur because the cases have been ruminating about their exposure history, their family's exposure history, what their child was exposed to. The cases may have their own pet theories about what caused their exposure. The cases may be more or less truthful about their exposure history, especially with sensitive exposures, right? We talked about, abortion history. And what happens then is that, again, if we think about our 2x2 table, it's not random. It's not arbitrary whether someone, correctly reports or incorrectly reports their exposure history. There are consistent directions that the cases, say in, a specific case, may be less likely to report their exposure history than their controls because they're more embarrassed about something. So it's that consistency of error. And specifically, as you may be catching on, recall bias or information bias is bad when it's consistently error in one cell. So it's not just cases are miscategorized on their exposure history. It's that the cases with the exposure are going to be putting themselves into the cases without the exposure cell because they're embarrassed, right? So we'll go through, start to get a sense of this, just start to kind of think about this and hopefully we'll get you there at the end. It could also happen because of diagnostic or detection bias, right? And so individuals with an exposure may be more likely to seek medical attention, maybe more followed by their healthcare provider, and so they're more likely to end up being diagnosed with a health outcome than someone else who didn't have that exposure history. So that information on them it's differently wrong, or in this case, it may be differently correct than someone who didn't have that exposure history. Interviewer bias is another way. So it's the systematic difference in soliciting, recording, or interpreting information that occurs in studies using interviews, where there's, say a research assistant and they're asking a participant some questions. So it can occur if the interviewer is aware of the exposure disease status of the participant, or they are aware if in an experimental study if someone's been assigned to a condition, which we'll learn about in a couple weeks. So for example, when I was a research assistant a long time ago, I worked on a study to help women who were pregnant quit smoking. So half of these women had been assigned to receive nursing visits that talked about smoking along with giving prenatal care, and the other half of participants were randomly assigned to not receive any extra support. So I was this research assistant. I went out to all these homes and I had to interview these women about their smoking patterns. Now, if I wasn't very careful and stick to the protocol, there's a real potential, right? I know which women are getting the nursing visits, because they may have told me, oh, the nurse was here last week and we talked about this. So if I'm not careful, there's a real sort of tendency to have in my head, oh, these are the women who, receive the nursing visits. And the nursing visits, right, we're giving them all this extra attention and we're talking about quitting smoking. And, they said, and then you go, they said that they smoked a cigarette yesterday, but it was only half a cigarette. So I'm going to, put them as not having smoked yesterday instead of having smoked a full cigarette, right? So there's bias that's introduced by reviewers or interviewers unintentionally often, because we're all sort of human beings. And if things aren't, crystal clear, then we need to make calls about, does this count as smoking or does this count not as smoking? And just that happens. And there are ways that we can prevent that kind of bias from an interviewer from happening. Masking or blinding helps, right? So like if I didn't know which women were assigned to the nursing condition or the no nurse condition, but there may be things, as I said, that the participant says during the course of the data collection interview that unblinds you. It's also really good to use standardized questionnaires with close-ended questions. So it's not a situation where, again, in my example, the woman's telling me, on and on about how much she smoked and how much she's cut back. But I say very explicitly, did you smoke any cigarettes yesterday? Yes, no. That would help reduce the potential that I would say, oh, it's not really that much. And then also careful protocols and consistent observations. So when you're running a study, it's very important to have your staff and your interviewers and your data collectors be extremely consistent, because as you can imagine, through this story as an example, this kind of bias tends to creep up on us, and we're all trying to do the right thing, and we may not even realize, if say you're weighing and measuring someone for a weight loss study, and someone comes up to you and they're talking about how they've been trying so hard and they've really been cutting down on their calories and et cetera, et cetera. You as an interviewer might say, oh, you're 150.5 pounds, but I'm going to put that as 150. No one does this on purpose, but again, we're all human beings, and this bias tends to creep in where we misclassify people, we misrecord information systematically, not as sort of a random, like, oh, some are a little low, some are a little high, but in this case, in these stories, we've systematically incorrectly classified people's data based on what we know about their exposure status or what arm of the study they're in, things like that. Those problems, those behaviors of misclassifying people introduce major problems into your study. Okay, so we have information bias. We have the wrong information in our studies, and it's systematically wrong based on someone's exposure status or someone's disease or outcome status. It's not just this random noise like we talked about earlier. What happens when we have information bias? The outcome is something called misclassification. I've been talking about this a little bit. And misclassification occurs when you are consistently incorrectly assigning subjects to either exposure status or outcome status. And so what happens is some of your exposed participants are classified as unexposed or vice versa. Some of your participants with your outcome are classified as not having your outcome. Basically, again, think about your 2x2 tables, and people are ending up in the wrong cells in a systematic way. There's two ways that we can misclassify people, right? There's something called non-differential misclassification, and that's when the likelihood of misclassification is the same between study groups. So the idea is that you may misclassify exposure status, but you misclassify exposure status the same for your cases and controls. So say you have a case control study and you're an interviewer in it, and say you're a bad interviewer and you're not being consistent, and you consistently, whether someone's your case or your control, underestimating their exposure. So you're putting both your cases and controls into the wrong cells. That's non-differential misclassification. It can go the other way, right? So for both your exposed and your unexposed, say you're whatever process you use to determine if someone has your disease, say you're incorrectly classifying people as diseased who are not diseased, right? So for both your exposed and your unexposed groups, people are incorrectly going into your diseased column when they should be going into your non-diseased column. That's non-differential. It's happening equally to either your exposed and unexposed or your cases and your controls. Non-differential. And what the outcome of that when you start to calculate your relative risks and your odds ratios is that usually your exposure disease association is going to be biased toward the null. So you're going to end up with a relative risk or an odds ratio closer to 1 if you've done this non-differential misclassification where people are just in the wrong, like consistently in the wrong boxes, and it's not dependent on their exposure status or their outcome status. They're just, you're consistently underestimating, you're consistently overestimating. You're going to usually end up with a bias toward the null. Well, what are the implications of that? That there may be a true association, a true causal association out in the world that you're not going to see because you measured things wrong. And that just sucks, right? You've spent millions of dollars in this study and you've misclassified people non-differentially, and you don't see an association that truly exists. The alternative, while that's disappointing, the alternative is actually much worse. So the alternative, let me see if I zoom in here. Oh, it doesn't zoom. Okay, something happened to my slides. I'll fix it. But the alternative is differential misclassification. And the idea with differential misclassification is that the likelihood of misclassification differs between study groups. So think about a case control study. You have your cases and your controls. If you have a situation where your cases are much more likely to be classified as exposed, even when they're not, than your controls, right? And those are some of the examples that we've talked about up here, right, with recall bias. So your cases are differently classified and differently or incorrectly classified than your controls. The same thing can happen with a cohort study, and that's the example we talked about here up there with the doctor and the x-rays. In a cohort study, say you're exposed are more likely to be accurately classified as diseased, while your unexposed are more likely to be inaccurately classified, right? So again, think about your 2x2 table and sort of the two axes. You have your exposed and your unexposed and your diseased and your non-diseased. And differential misclassification is when everyone is sort of shifted over. They're either shifted over a column or shifted over a row, and it's not dependent on the other axes, right? So the exposed become unexposed, the cases become controls, whatever it is, everyone's just sort of shifted, and it's bad. But it's even worse if one of those cells is shifted, when that incorrect information is based on both of your axes, your exposure status and your disease status. Okay, so let's go through a few scenarios. Move this over. So sometimes there's not necessarily a right or wrong answer with these, but it's more about the justification. So I'm going to talk through my justification on how I would answer these, but you're certainly willing to think of this, or able to think of a situation where potentially something is differential and I think it's non-differential. So let's go through these 4 situations, and I'm going to talk through my thought process about whether we ended up with differential classification or non-differential misclassification. So say we had a case control study that relies on medical records to determine exposure history, right? So we have lung cancer cases. We have lung cancer cases, and then we have our controls who don't have lung cancer, and we're looking for their exposure history based on their medical records. So lung cancer patients were more likely to see their doctor due to complaints about their breathing and thus have their smoking status noted on their chart more often, right? Because so people may have had preclinical disease, they're having trouble breathing. Their doctors making sure to note that they're smokers in their medical records, and then they end up with lung cancer. Meanwhile, your controls, right, had no reason to go see the doctor. They weren't having breathing problems. They had no reason for their, the doctor's suspicions to be raised about smoking. So maybe the doctor didn't ask them as often about their smoking status, or maybe they didn't record it. So in this case, we're going to have differential misclassification. So your cases, the smoking status, the exposure status for your cases is more likely to be accurately noted in the medical records than the smoking status of your controls. You end up with differential misclassification. Your exposed cases, that quadrant of your 2x2 table is more correct, let's say, than the other quadrants, the information in the other quadrants. Okay, so bullet number 2. In a cohort study to examine whether eating a high-protein diet is associated with lower fasting glucose levels, the machine to calculate blood sugar was not calibrated correctly, and consistently low results are given. So in this case, we have non-differential. So it doesn't, our exposure is eating a high protein diet. Our outcome is lower fasting glucose levels. So our machine to calculate blood sugar is categorizing our outcome status, but it's consistently giving low results, right? So it's consistently, whether someone eats a low or a high protein diet or not, is classifying people as having low fasting glucose, even if they perhaps even had high fasting glucose. So the outcome status is wrong. It's consistently wrong, but it's not dependent on their exposure status. So that is non-differential. Okay, so our third bullet. In a case control study of birth defects and prescription drug use during pregnancy, exposure status was determined by whether a woman filled a prescription for specific drugs within 2 years before the child's birth. Okay, case control study. We have children with birth defects, who are our cases, and without birth defects, who are our controls. We're now looking at our exposure status, prescription drug use, to see if it's associated with case or control status. And we determined whether someone had used these prescription drugs by looking at their prescription drug history in the 2 years before the child's birth. So I would say this is non-differential. The exposure status was determined and was, people were exposed before the child was born with this with the birth defect. Sorry, I was just confirming something. So we're getting this for prescription drug histories and whether they filled the drug. Although I'm realizing now it doesn't explicitly say this, but my intention was that it was not from the mom saying, yes, I took this drug, but from records of whether the prescription was filled. Now, there's some issues, right? We fill prescriptions all the time and people don't take them. But again, regardless, it's non-differential because the birth defects, the record of exposure, whether the prescription was filled or not, occurred before the birth defects. And so whether the child was a case or a control. So the inaccuracies of whether the woman filled the prescription or took the prescription aren't dependent on whether her child had birth defects or not. So again, non-differential in this case. Number 4, in a cohort study to examine mothers' alcohol use and children's behavioral problems in preschool, behavioral problems were ascertained based on teacher records of having to discipline a child. Cohort study, our exposures are mother's alcohol use. Our outcomes are children's behavioral problems, and we're assessing the outcomes by teacher report. Now, I can actually see two situations here. So at first I would say non-differential, right? So whether or not a teacher reports having to discipline a child should be unrelated to the mother's alcohol use. So how we're classifying the child's outcome is not different based on mother's alcohol use, whether we're accurately or inaccurately classifying those disciplinary actions. So that would be non-differential. Whether or not mom uses alcohol is unrelated to the error of classifying a child as having been disciplined. However, I could see another situation where perhaps the teacher, right, has interacted with the mother. Say she was an alcoholic, right? And so maybe that teacher remembers disciplining that child differently, and her records reflect different discipline occurrences because the teacher was aware of the mother's alcohol use. In that case, it could be differential. So the error or the classification of our outcome, whether or not the child was disciplined, may be in part based on the child's exposure status. So it may be different because teacher was aware of mom's alcohol problems or not. So, hopefully you can see those two different scenarios and, you can make a decision for yourself about which seems more or less likely. And in this case, you just have to provide a justification. So what do we do to reduce information bias? What do we do to reduce this error in how people are classified either in their exposure status or their outcome status? There are a lot of things we can do. We try to use well-tested instruments. So we want instruments that are accurate, that have been calibrated, that are consistent, that are not going to either differentially or non-differentially mismeasure our outcomes, whether it's, a measurement of blood glucose, a physical measurement, a survey item. We want good, valid, truthful measurements. We also keep close tabs on administration of study instruments, as I was saying in the example before. If you have a lot of interviewers out in the field, you want, as a manager of those interviewers, to review the protocol with them, perhaps to observe how they're doing the measurements, to check in with them. Perhaps sometimes you might have 2 research assistants going out and doing the measurements on the same person to make sure that they are reliable and that they match each other. Those are ways to ensure that there's not going to be a mismeasurement, and importantly, not a systematic mismeasurement. So some people are consistently mismeasured in the same direction. We try to use objective versus subjective methods. So again, if you can draw blood on a subject, if you can get, an X-ray or a medical record, that tends to be a lot better than a subject self-report of I have diabetes, or I've been told I, have high blood pressure, something like that. And then we try to maintain blindness by both participants and study staff to their exposure status or control status, especially in these randomized experiments where people are assigned to an exposure, right? And you can imagine the typical situation of a medication. We don't want people reporting symptoms because they know they got this active study medication, because that's going to misclassify them based on their exposure status. So there's a lot of things that we can do to make our studies really clean and tight and use good measures. The bottom line is, right, we don't want anyone ending up in the wrong cells to be misclassified based on their exposure and outcome status. And now importantly, just to wrap up this lecture, so we talked at the beginning of the lecture, the beginning of this series of videos, about random error or chance, right? When we take samples from our population, those samples may not reflect the true underlying population. We have all sorts of measures that have this noise and they're not as precise as we would like. The way to overcome that random error is to do bigger studies, because the more people you get in your sample, the more representative they're going to be of the underlying population, and the greater, the more you can reduce the noise or the slight variability in your measures. And so this is a measure of your standard error for those of you who are in biostats. Larger sample size, smaller standard errors, because standard error is dependent on the standard deviation and the n of your sample. So with bigger study size, with bigger study samples, we can reduce the problem of random error. Systematic error, though, by what we have been calling bias, cannot be reduced by larger sample sizes. If you made an error of who is in your study, if you made an error of what you've measured in your study, and you are systematically or consistently misclassifying people, it doesn't matter if you have 10 people in your study, 100, 1,000, you're going to have those errors, and your measures of association are not going to be accurate estimates of your causal effect. All right, so that's it for this lecture. I know it can be, again, to me at least, it seems like a topic that may not be quite tangible, so it may take a few times of either listening to this, or I highly recommend you go and read the book. And of course, please contact me if you have any questions.